I have talked on, that is the blood pressure and regulation, and say that was our first part, and I have told you there are various mechanisms which exist here to control, that is blood pressure. Now we have broadly categorized this all regulatory mechanism in three groups or categories, you may say, that is rapidly and short acting mechanisms, and intermediate acting mechanisms, and long term acting mechanisms. Under rapidly short acting mechanisms, what we have seen is, that is baroreceptors, chemoreceptor, CNS ischemic response, and other rapidly acting mechanisms which are included under this category: low pressure receptors, Bell-bridge reflex, volume receptors. Then the second category is intermediate acting mechanisms. These are capillary fluid shift mechanisms and stress relaxation of blood vessel. And what we were discussing last time was long-term acting mechanism. So far, under that I have covered here, that is the renin-angiotensin system. And second that we have to discuss today is that a renal, that is body fluid system. Now just give a look to this figure. If you remember that we have seen, that is the renin-angiotensin system. Just to revise is that whenever there occurs a decrease in the blood pressure, we know there is a secretion of the renin from the kidney, that is the juxtaglomerular apparatus, and the secreted renin, this acts on, that is the alpha 2 type of globulin, that is what we call as the angiotensinogen, that is the plasma protein, which is converted to angiotensin 1, that is a decapeptide, and then it through circulation it reaches to the lung, since there is a converting enzyme that we call as the angiotensin converting enzyme, that is, and here angiotensin 1 gets converted into angiotensin 2. Now there are two effects of angiotensin 2. It causes first, that is the vasoconstriction to increase the blood pressure. Secondly, it acts on, that is the the kidney, on the adrenal cortex, to cause release of aldosterone. What is the action of that is the aldosterone? It causes the increased water and sodium retention, and also helps here by maintaining that is the volume, that is the it helps here to increase the blood pressure. Similarly, further angiotensin 2 is degraded into that is the angiotensin 3, and it is converted by enzyme angiotensinase, and this was the about renin-angiotensin system. Then it is followed by, that is the second mechanism, what we call it as, that is a renal body fluid system. This is a primitive system which also is developed in lower animals. It is a simple system in which output for excretion of water, H2O, and salt, sodium, by the kidney is very sensitive to pressure changes. For example, whenever there is increase in the blood volume, it causes increase in the blood pressure. Due to this blood pressure, the kidneys excrete excessive amount of H2O, that is, and salt. This is called as, that is a diuresis and natriuresis, because it is due to an increase in the blood pressure, which is also called as pressure diuresis, and the pressure that is, it is called pressure diuresis. When blood pressure is about approximately 15 mm of mercury, there is no output of water and salt by the kidney. When the pressure is about 100 mm of mercury, the output is normally not. If pressure assume that it increases to the 200 mm of mercury, the output increases to 6 to 8 times than normal level. Whenever there is rise in the extracellular fluid, blood pressure rises, and kidneys will excrete extra amount of fluid and sodium till the blood pressure comes to normal. If there is decrease in the extracellular fluid, blood pressure will decrease, and excretion of water and salt will decrease, and both will be retained till blood pressure becomes normal. And similarly, exactly opposite effects are seen when salt intake is, that is the decrease, means it acts in the other way, to normalize, that is the blood pressure. So for example, the same mechanism, just I have told you, means what we have seen, that is exactly opposite effect will be seen when the salt intake is decreased. Now as shown in the figure, suppose that if the salt there will occur, that is the salt intake is increased, then there will occur increase in the extracellular fluid, there will occur increase in the arterial blood pressure, there will occur increase in the renal blood flow, and that will cause here retention of salt and water, and that will help here to cause return of extracellular fluid volume to normal, and that way it helps here to maintain that is the normal blood pressure, or it helps to return of that is blood pressure to the normal level. Now regarding the renal that is body fluid system, two factors determine the functioning of the system. Number one, excretion of salt and water by the kidneys. Second, the intake of salt and water by individual. Whenever there is a decrease in intake of water or increase in salt intake, the body causes increase in the extracellular fluid volume to maintain a normal osmolarity. Osmolarity is nothing but it is osmoles per liter of plasma. And hence, increasing the extracellular fluid is caused by two mechanisms. Increase osmolarity of extracellular volume stimulate the thirst center, which will cause increased intake of water, hence osmolarity becomes normal. Secondly, increased osmolarity stimulates the very important aspect, secretion of ADH, which acts on kidneys to cause reabsorption of water, and hence increased water also helps to bring osmolarity to normal. Now there is other that is long-term mechanisms which are included. For example, the role of antidiuretic hormone. The second mechanism by which blood pressure is regulated is release of antidiuretic hormone from the supraoptic nucleus of the hypothalamus in the response to the thirst or an increased plasma osmolarity. Now, what is the role of ADH? ADH acts to increase the permeability of the collecting duct to water by inserting aquaporine channels, or you may say increase number of aquaporine channels, that is called AQP2, into the apical membrane. It also stimulates sodium reabsorption from the thick ascending limb of the loop of the Henle. This increases water reabsorption, thus increasing plasma volume, and that is the decreasing osmolarity. Now there are also there are other mechanisms or substances which are used in the long-term acting mechanism. For example, there are some of the further control mechanism for blood pressure, that other factors also which can affect long-term regulation of blood pressure are natriuretic peptides. These include, now it is very commonly called as a ANP or atrial natriuretic peptide, which is synthesized and stored in the cardiac myocyte. It is released when atria are stretched and indicating of that is a high blood pressure. Atrial natriuretic peptides acts to promote sodium excretion. It helps to dilate the afferent arterioles of the glomerulus, increasing blood flow. Moreover, that is the atrial natriuretic peptide inhibits sodium reabsorption along the nephron. Conversely, remember that is ANP secretion is low when blood pressure is that is low. The second group is that of the substances that very commonly we know that prostaglandins, which acts as a local vasodilator to increase GFR and reduce sodium reabsorption. They also act to prevent excessive vasoconstriction triggered by the sympathetic nervous and the renin angiotensin that is the aldosterone system. Now there are also, we come across one term, that is a local regulation of the blood pressure. Now as I already told you, there are different mechanisms have been described for the regulation of the blood pressure. In some of the books we will find that they mention even that is how this blood pressure is regulated by local mechanism, and that is called as local regulation of blood pressure. Now remember that tissues and the organs within the body are able to intrinsically regulate varying degree their own blood that is supply in order to meet their metabolic and the functional needs. This is termed as local or intrinsic regulation of blood pressure. In short, this is the ability of the body or some of the tissues and the organs to regulate that is the blood pressure as per the variation which occurs in the blood supply. Now the local regulatory mechanisms acts independently of extrinsic control mechanisms such as sympathetic nerves and circulating hormones. Therefore, they can be demonstrated in isolated perfused organs having no neurohormonal influences. Ultimately, the balance between local regulatory mechanisms and extrinsic factors in, say, vivo determine the vascular tone and therefore the blood flow within the tissue. Now, there are some of the examples of the local regulation of the blood flow which include the following, that is the autoregulation proper. We come across a term hyperemia. There are two types of the hyperemia. There are, say, many types, but for our discussion we will consider some of them. That is the active hyperemia, reactive hyperemia. What do you mean by the hyperemia? Hyperemia refers to a localized increase in the blood volume of a particle tissue due to the local arterial dilation. It can affect many different organs including the liver, heart, skin, eyes and brain. Now, as I already told you, there are two types of, say, active hyperemia, that is hyperemia, that we call the active hyperemia and reactive hyperemia. In short, say, reactive hyperemia is the blood flow, say, in response to blood flow occlusion, whereas active hyperemia is the blood flow that is response to increased tissue metabolic activity. Just I will repeat here. Reactive hyperemia is the blood flow, say, response to blood flow occlusion, whereas active hyperemia is the blood flow response to the increased tissue metabolic activity. Now, regarding, say, that is the local, say, that is the regulation of the blood. Now, just say in short we will say that we first see the mechanism of the auto-regulation. The capacity, it is nothing but it is the capacity of the tissues to regulate their own blood pressure is called as auto-regulation. It is defined as the intrinsic ability of an organ to maintain a constant, say, that is the blood pressure, blood flow, despite the changes in the perfusion pressure. Now it is nothing but, say, that is the, what is the perfusion pressure? Arterial minus venous pressure. Different organs display, that is the varying degrees of auto-regulatory behavior. For example, the renal, cerebral and the coronary circulation show excellent, say, auto-regulation mechanism, whereas skeletal muscle and splanchnic circulation show moderate auto-regulation. The cutaneous circulation also shows little or no regulatory, say, that is the capacity. Now, question arises, under what conditions does auto-regulation occur and why it is important? A change in the, say, systemic arterial pressure as occurs, for example, with hypotension caused by hypovolemia or that is circulatory shock can lead to autoregulatory responses in certain organs. This autoregulation is particularly important in some of the organs such as the brain, heart and kidney, in which partial occlusion of the large arteries can lead to significant reduction in oxygen delivery, thereby leading to tissue hypoxia and organ dysfunction. Autoregulation is present in many vascular beds, but is particularly well developed, as I already told you, in the brain, kidney, mesentery, skeletal muscle, liver and myocardium. There are some of the theories regarding the autoregulation. That is the myogenic theory of autoregulation and the metabolic theory of autoregulation. In the myogenic theory of autoregulation, it is due to the intrinsic contractile response of the smooth muscle to stretch. Means when pressure rises, the blood vessels are distended and the vascular smooth muscle fibers surrounding the vessel contract. It follows the Laplace law. Now, there are some of the vasodilator substances which accumulate during slower blood flow in active tissues to cause autoregulation, and this is the part of metabolic theory of autoregulation. The brain blood flow autoregulation is abolished in several diseases states such as traumatic brain injury, stroke, brain tumors or persistent abnormally high carbon dioxide level. Regulation of renal flow is important to maintain a stable glomerular filtration rate despite changes in, say, that is systemic blood pressure in the range of, say, that is 80 to 180 mm of mercury. In mechanism called, if you remember that, tubuloglomerular feedback, the kidney change its own blood flow in the response to changes in, that is the sodium concentration. Now just give a look to, say, this figure. it shows mean arterial pressure, and this is the cerebral flow. Now what I want to explain here is the cerebral autoregulation. Now this part, say that is in the range of somewhere, we will say that is the more than that is 80 to say that is about 180, that is about say that is in the range of 150 mm. We will find there will occur say constant of the blood flow and blood pressure will be maintained. If there occurs fall in the say blood pressure, there will occur cerebral hypoxia, and that will cause here say vasodilation, and by decreasing here blood pressure. On contrary, suppose that if the blood pressure increases, what happens? Now there occurs the constriction of the blood, say that is the blood vessel, and say it causes headaches, then the disruption in the blood, there is a blood-brain barrier, and it will lead to the say that is the edema. Now in the cerebral autoregulation, what may be the possible say mechanisms that is there are say, as I already told you, one cause is say metabolic and other is say that is the myogenic. In the metabolic, you will find that say decreased perfusion pressure leads to decrease in the partial pressure of oxygen, and that will say cause decrease say in the oxygen delivery. Now whenever there is say increase in the partial pressure of carbon dioxide, what does it mean? It means that there is an accumulation of the say carbon dioxide, and there say exists decreased carbon dioxide washout. If there is an increase in the hydrogen concentration, mean what does it mean? Decreased hydrogen washout plus there is accumulation of lactic acid. On contrary, there you will find that there is an increase in the adenosine, that which results say that is due to the hypoxia resulting in the net loss of ATP. Each of the above changes very importantly cause here say vasodilation. In the myogenic say that is the aspect, decreased perfusion pressure decreases stretching of the arterial smooth muscle, which causes here that is the relaxation. Similarly, you can see in this figure that is say the variation in the say autoregulation say of the say the cerebral blood flow. This say blue indicates here say normotensive, and here in the say that hypertension you will find shifting of the curve towards the right. Now it causes the say risk of say injury from excessive treatment, say or treatment of cerebral ischemia, or it also leads to the some of the complications when there is an increase of the chronic say hypertension. For example, that is it will cause that is complications from acute severe hypertension such as diffuse endothelial injury, the retinal damage, and that is the cerebral edema. Now the second aspect is say in the autoregulation, there are some of the vasodilator metabolites which are present. So decrease in the partial pressure of say oxygen, and that is the pH in most of the tissues produce vasodilation. It is well known thing. These changes cause relaxation of the arterioles and the precapillary sphincters. Increase in the partial pressure of carbon dioxide and osmolality also dilate the vessels. Similarly, increase in the temperature and the accumulation of potassium ions also contribute to the vasodilation. Lactate may also contribute the vasodilation. Metabolites which are produced here in the body due to the metabolism, and they here help here to say somehow to help here to increase the say the blood flow due to the vasodilation. When there, as we know that whenever there occurs the vasodilation, it is very clear indication that there occurs decrease in the blood pressure. Now there are, apart from that, there are some of the vasoconstrictor substances also produced, and they produce here localized vasoconstriction. Say for example, injured arteries and the arterioles constrict strongly. This constriction is mainly caused in part to the local secretion of serotonin. Now mostly it is found in the brain and bowels, and that is the platelets. And here say remember that injured veins also constrict. The decrease in the temperature also causes vasoconstriction. Remember, in the vasodilator metabolites we have seen what is the effect of the increased temperature that causes the vasodilation, and here decrease in the temperature also causes the vasoconstriction. This is the commonest phenomenon that which you observe during say that is the winter season. Now there are some of the substances which are secreted by the endothelium. Endothelium secretes, say, that is the many growth factors and vasoactive substances such as prostaglandin, thromboxanes, nitric oxide, that is NO, and endothelium. Prostacyclin is produced by endothelial cells and thromboxane A2 by platelets. What is the role of thromboxane A2? Thromboxane A2 promotes platelet aggregation and vasoconstriction, whereas prostacyclin inhibits platelet aggregation and promote vasoconstriction. Then endothelium also secrete some of the other factors. For example, endothelium derived releasing factor, which we call commonly as EDRF or nitrous oxide, that is say NO, which is also say cause that is the say vasodilation. So similarly, what is the role of carbon monoxide? Carbon monoxide produces local dilation in the blood vessel. The endothelial cells also produce the substance endothelin 1, which also acts as a potent vasoconstriction. Many circulating substances affect the vascular system, just help here to regulate the blood pressure, such as the circulating, say, that is the vasodilator substances as kinins, bradykinins and calidin. VIP means that is vasoactive intestinal peptide. ANP, just we have seen, atrial natriuretic peptide secreted by atria. Circulating, say, that is the vasoconstrictor hormones include vasopressin, norepinephrine, epinephrine and angiotensin. Now coming to the say, that is a hyperemia, that is, as I already told you, that is hyperemia is nothing but it is the accumulation of the blood, or say, as we have seen that there are two types of, say, that is the hyperemia, that is a active hyperemia and reactive hyperemia. In active hyperemia is the increase in the organ blood flow. Hyperemia that is associated with the increased metabolic activity of an organ or tissue. Means active hyperemia is what? Is the increase in the organ blood flow that is associated with the increased metabolic activity of an organ or tissue. An example of active hyperemia is the increase in the blood flow that accompanies muscle contraction, which is also called as exercise or functional hyperemia in skeletal muscle. I mean, what does it mean? Hyperemia here helps to increase the blood flow when body needs in the, say, under extend, that is the strenuous activity. Blood flow increases because the increased oxygen consumption of the during, say, muscle contraction stimulates the production of vasoactive substances which dilate the resistance vessels in the skeletal muscle just to increase the, say, blood flow. Now there are other examples of say that active hyperemia, which include the increase in the gastrointestinal blood flow during digestion of the food, the increase in the coronary blood flow when heart rate is increased, and the increase in the cerebral blood flow associated with increased neuronal activity in the brain. Now just to give you the example of hyperemia here, say this is the normal, say, activity of the blood flow, capillary bed, and that is there is a hyperemia, we call it erythema. Here, say, find the increase, say, in flow when that is, say, occurs due to the, say, that is exercise or that is inflammation. Then now here just give a look to this figure. It shows here the effect of, say, oxygen consumption to the blood flow. Say this shows the resting blood flow and increase in the, say, that is the blood flow as per the increase in the oxygen consumption. The figure shows that there is a resting flow associated with the basal oxygen consumption of the tissue. As say the oxygen consumption increases, there is greatly a near linear, say, increase in blood flow until the vessels begin to achieve a maximally dilated state, just by, and which helps here to increase the blood flow. The magnitude of the active hyperemia responses differ among organs because of the relative changes in the metabolic activity from rest and their vasodilatory capacity. In short, say, that is the active hyperemia, say, depends on metabolic activity. Similarly, active hyperemia can result in up to a 50-fold increase in the muscle blood flow with maximal exercise, whereas cerebral flow may only increase 2-fold with increased neuronal activity. Now, say regarding active hyperemia, which can also be influenced by competing vasoconstrictor mechanism. For example, sympathetic activation during exercise can reduce the maximal skeletal muscle active hyperemia compared to what would occur in the absence of sympathetic activation. Active hyperemia may be due to combination of tissue hypoxia and generation of vasodilator metabolites such as potassium ion, carbon dioxide, nitric oxide, and that is the adenosine. Then comes here, that is the second category, what we call it as reactive hyperemia. The reactive hyperemia is the transient increase in the organ blood flow which occurs, say, following a brief period of ischemia. For example, arterial occlusion. It occurs due to arterial occlusion. This once again we will go back to this part. Say reactive hyperemia is what? Is the transient increase in the organ blood flow which occurs following a brief period of ischemia, that is arterial occlusion. The reactive hyperemia occurs following the removal of a tourniquet arm cuff during recording of blood pressure. Now, if you remember that, say while recording the blood pressure, so what we do, we apply this arm cufflet over the upper arm of the hand and increase the pressure, due to which there occurs the occlusion of the artery, means blood is stopped. When that is the removal of the arm cuff, say that will cause, say that is the means surge in the rush of the blood. Similarly, unclamping an artery during surgery or restoring flow to a coronary artery after recanalization, or say reopening of a closed artery using an angioplasty balloon or a clot dissolving drug, which say cause transient increase in the organ blood flow. In general, the ability of an organ to display reactive hyperemia is similar to its ability to display autoregulation. During the hyperemia, the tissue becomes reoxygenated and vasodilator metabolites are washed out of the tissue. This causes the resistant vessels to regain their normal vascular tone and thereby retaining flow to the control. The longer the period of the occlusion, what you will find, the greater metabolic stimulus for vasodilation, leading to increase in the peak reactive hyperemia and duration of, say, that is the hyperemia. During hyperemia, the tissues depending upon, say, the organ, maximal vasodilation as indicated by peak flow may occur following less than 1 minute. Coronary circulation, say, of complete arterial occlusion, or may require several minutes of occlusion. Mean in short, say, depending upon the organ maximum vasodilation will occur as indicated by peak flow, which may occur following less than 1 minute or occlusion of, say, artery, or may require here several minutes of occlusion, for example, gastrointestinal circulation. Similarly, say in the myogenic mechanism, here also may also contribute to reactive hyperemia in some tissues. By this mechanism, arterial occlusion results in a decrease in the pressure downstream in arteries, which can lead to the myogenic mediated vasodilation. Now just give a look to this figure of the reactive, say, that is the hyperemia. Here, say, blood flow is, say, that is occluded just for, say, that is the 2 minutes, and immediately after that you will find that is there will occur increase in the peak flow. I mean there you will find excessive flow, then it's a normal. And in, say, reactive hyperemia you will find that is the what we have defined increase in the blood flow after removal of the occlusion. Now occlusion duration, it shows the here, say, that is it will cause excessive, say, flow or hyperemia duration. Now here accordingly, if it is, say, you will find that accordingly you will find there will occur increase in the, say, flow. Similarly, now there is, say, there are various types of the hyperemia. The second is the what we call as a passive hyperemia, or very commonly it is called as a congestion. It results from impaired venous drainage or venous return, and it leads to accumulation of blood on the venous side of the circulation, and which cause here with blue-red coloration of the affected part as blood is deoxygenated. The concept is that it results from the impaired venous drainage or blockage of the venous return, and it leads to accumulation of the blood on the venous side of the circulation with the blue-red coloration causing the blue-red coloration of the affected part as the blood is deoxygenated. And congestion is almost always observed as a pathological condition. Now just to give you idea about this in short, this is the accumulation. Whenever there is a blockage of the venous return, what will cause that it will cause engorgement of the blood in the capillaries, and it will cause the blue coloration. Now it will cause due to the, for example, local obstruction or congestive heart failure. Now here tissue is blue due to the engorgement and deoxygenated, that is the blood. Means in short, what so far I have covered is that is the regulation of, that is the the blood pressure mechanism. Just to summarize here, I will not go into that much details of this at present, but yes. Now just give a look to this figure, that is which are the mechanisms which we have studied. Mechanism for blood pressure regulation we have studied here. Just please excuse me, I think there is something. Okay, let it be. Then we have seen here, it is we have studied here about the three types of the mechanism. What are they? Rapidly acting or short acting mechanism, then intermediate, that is the acting mechanism, and the that is the this long term regulating mechanism. Remember that one important thing, that we have seen the various types of the mechanism which were included here in this all these three categories. Just to summarize here, in the rapidly short acting mechanism, we have studied here three categories: baroreceptors, chemoreceptors, and CNS ischemic response. Why they are called rapidly? Because they come into action within very short time. And there are also other rapidly acting mechanisms, what we call as the low pressure receptors, bend bridge reflex, volume receptors, and it is followed by intermediate acting mechanism. There are two important mechanisms which are included here: capillary fluid shift mechanism and stress relaxation of blood vessels. And long-term acting mechanism that we have seen is the renin-angiotensin system and the renal body fluid and other substances. And in the local regulatory mechanism, we have also studied here, that is the what is the action of the that is the local metabolic activities and so on. Last part which we dealt was that is the what is the role of, that is the hyperemia and the types of hyperemia. I stop here. Thank you very much for watching. Thank you very much. तिथून कसं तिथून बंद करता येतं? हो. कुठलं बटन दाबलं की